Well, thank you, Tom. It's a pleasure to be here and tell you a little bit about some background from an endocrinologist perspective on this problem, and then hopefully some plans that are ongoing to try to address this at Yale in hopefully our own special way. So the reason I'm here talking to you about this today is nicely summed up in this slide, stolen from a review from Sue Brown and Teresa Guys, showing that basically the things that you all do to patients, that is helping patients live longer, thank you very much, but it has consequences, as you know, for a lot of side effects, both acutely and then in survivors, cancer survivors, long-term side effects. So you can see here that if you look at normal bone loss, if I look at my computer screen, I have to wear my glasses, sorry. Then you can see normal men lose a little bit of bone on a yearly basis. Late and early menopausal women are here, but aromatase inhibitor, exemestane, as Tom was saying, bone marrow transplant, androgen deprivation therapy, and prostate cancer. And if you're unlucky enough to be a young woman with breast or other cancer and get put on a GnRH inhibitor or have a ovarian failure secondary to chemotherapy, you get very significant amounts of bone loss per year. Of course, this has consequences, and the consequences are fractures. So this is, we're going to talk mostly about breast cancer today as an example, but this is true of several cancers, which I'll illustrate. But you can see in this study from John Canis in the UK that what he did here is it's a little hard reading this paper to see how well controlled this case control study was. But 434 cases and 776 controls, and basically in the controls they did followed from the same time as the breast cancer presentation, and these were all patients without bone metastases. And you can see that they were followed for 2 to 3 years, that the incidence of fractures was much higher in the patients with breast cancer than those patients without breast cancer. And in patients who had within that time frame, a recurrence in soft tissue, but still no bone mets, so presumably more aggressive tumors, that their fracture incidence was very elevated compared to the controls. So implying that simply having a diagnosis of breast cancer increases your risk of fracture, osteoporotic fracture. This is a little bit better controlled study from the Women's Health Initiative, which was a prospective cohort observational study, and you can see that these were all postmenopausal women, and again, breast cancer survivors, no bone metastases, and you can see the incidence of various types of fractures with clearly an excess in total fractures in the last set of bars over here in patients with breast cancer compared to the controls. So this isn't true just for breast cancer. These are patients with prostate cancer from the Mayo Clinic, study in Olmsted County. Again, 742 patients followed for almost 7,000 person years. And if you had prostate cancer, you had a absolute fracture risk increased by 9%. The risk ratio or relative risk was 1.9. And the graphs are broken out on the left for patients without androgen deprivation therapy and patients with androgen deprivation therapy. This is a little bit of a dirty study in the sense that they didn't separate patients without in the follow-up period who presented with bone mets, so some of these are pathologic fractures as well as osteoporotic fractures. And of course, so breast cancer and prostate cancer are the two classic cancers that are associated with bone complications. Of course, many, almost all solid tumors can. The third big one is multiple myeloma, which again, you're talking about the tumor in intimate contact with the bone microenvironment, so it's a little hard to sort out how much of that is osteoporosis compared to pathologic fractures. But here's an interesting study, and these are just patients with MGUS, so without frank multiple myeloma, followed for 5 years in the first set and 10 years, and you can see that the hazard ratio for having all fractures here is clearly elevated, and none of these confidence intervals cross 1. So this is all a significant increase in fracture incidence just by virtue of having MGUS. So before we talk about this, and I said I'm going to concentrate mostly on breast cancer primarily because that's where we started because of my own research interests, but I'm going to give you a little bit of a primer on osteoporosis, or at least the way endocrinologists think about it, and then we'll talk about specifically what happens in breast cancer. So when we talk about osteoporosis in our clinic, we are talking about a definition that has three components. So the first is loss of bone mass, which is what we measure when we do DEXAs. The second is deterioration of bone microarchitecture. So if you have an extreme CT machine that you can put your heel in, you can actually measure trabecular microarchitecture, but we usually do this in dead mouse bones. And fragility fractures, so the 1 and 2 combine to increase the incidence of fracture. So this is what it looks like. Picture's worth a lot of words. So obviously you can see here over on the left, the osteoporotic bone has less stuff here, which is the white stuff. This is scanning EM with the marrow space, marrow elements gone. And you can see a deterioration in the microarchitecture. So these are the nice, healthy trabecular struts here. And you can see this is narrowed and this one's almost perforated. And it doesn't take a lot of imagination to imagine that if you hit the one on the left with a hammer versus the one on the right, it's going to smash a lot easier, right? So this is strong, and this is the kind of bone that leads to vertebral compression fractures, or if it's in your femoral neck, to a hip fracture. So this has consequences. The classic forms of osteoporotic fracture are vertebral fractures and hip fractures, as I said. So this is the same woman, 25 years apart, age 50 and age 75, suffering from osteoporosis. And you can see she already had a little bit of an exaggerated kyphosis here, but much more exaggerated. She's lost height. Her pelvic rim and her rib cage are now rubbing together. So this causes restrictive lung disease. It causes a lot of morbidity. It's uncomfortable, chronic back pain. So this causes suffering. Hip fractures are the other big fracture, and this not only causes suffering, but it causes excess mortality. So there's about a 20% excess mortality in the first year following a hip fracture, and whether that's just an indicator of frailty or whether that's specifically due to the hip fracture, practically it doesn't really matter. You're talking about a group of patients who are at high risk for dying in the year following their hip fracture, apart from whatever malignancy in this setting that we're going to talk about. So a word about the pathophysiology of osteoporosis. So all osteoporosis is caused by an imbalance in bone remodeling cycle, such that bone resorption, removing bone, outstrips bone formation, putting back new bone. So all of us in our skeleton, as we sit here, have this intricately orchestrated process of bone remodeling going on. Otherwise, we would accumulate micro fractures and gradually turn to dust, and we don't want to do that, so you have to continuously rebuild your skeleton. This is accomplished by these cells here, first of all, which are osteoclasts, which are fancy macrophages, essentially, derived from monocytes, and they are specialized to attach to the bone surface to pump out acid and proteases and to resorb the bone, both the proteinaceous material as well as dissolve the mineral part. These are stem cells at work. After you dig this pit, mesenchymal stem cells come in and decide to differentiate into osteoblasts instead of adipocytes. And we now know, you can see that you don't really see it here, this is all happening within a very close proximity to the bone marrow. So there is now increasing appreciation that hematopoietic stem cells, as well as hematopoietic progenitor cells of various stripes, talk to both osteoclasts and osteoblasts, and this is coordinated with what's going on in the marrow as well as just the skeleton. So these cells, once they're differentiated, lay down this proteinaceous stuff, and if there's enough calcium and phosphorus floating around, you form these, I don't have a picture here, beautiful hydroxyapatite crystals that get deposited into the bone proteinaceous matrix, facilitated by processes from these cells. So when we diagnose osteoporosis, we use a machine like this called the DEXA machine, which is simply measures the amount of ionizing radiation absorbed by the skeleton. It's a very small amount of radiation. It subtracts out the soft tissue component, and I'm sure you've all seen DEXA reports, clinicians who take care of these patients. One thing to keep in mind that's been evolving in the osteoporosis literature and in our world is that other risk factors have an important impact on fracture risk. Sometimes people get hung up on bone density numbers. We don't really care about fixing your bone density number. We care about preventing fractures, and that other factors are just as important as what the number is. So this shows the interaction between bone density and age. So you can have a T-score of -3, which is osteoporotic at age 50, and your absolute risk for fracture is much different than the same T-score in an 80-year-old. And you can see, you can take all the clinical risk factors that's been studied in large epidemiologic subsets of patients and come up with these kind of curves. These are the clinical risk factors that matter: increasing age, lack of estrogen, family history, so genetics, smoking, alcohol abuse, your BMI, your racial and ethnic background, which is essentially genetics, what medications you take, and the presence of other inflammatory diseases, including rheumatoid arthritis. So now there's a computer algorithm called FRAX that you can go to the FRAX website. And just to illustrate this, here is a woman who's age 57, doesn't smoke, doesn't have rheumatoid arthritis, and has a T-score of -2, and so has osteopenia, not osteoporosis. And what this does is calculate the estimated 10-year risk of absolute fractures. So the other thing we're trying to move away from is the tyranny of relative risk and try to actually come up with ways to predict absolute risk for events so we can choose to treat patients more wisely. And so this patient's absolute risk is 11% for any osteoporotic fracture. Sorry, my pointer is having troubles here. And then hip fracture risk of 1.6, which falls below the recommendations for treatment. Now, if you take this same T-score here, and now you make this woman 77 years old, she does smoke and she does have rheumatoid arthritis, you can see the huge difference, even though she has the same bone mass, that these clinical risk factors play in to predicting her absolute risk for fracture. All right, so that's kind of a quick spin through osteoporosis, and let's get back to breast cancer and cancer-related bone disease. So there's a lot of things in the treatment armamentarium for breast cancer that cause problems with the skeleton. So cytotoxic drugs induce premature menopause. They also have direct effects on the cells that build up bone, the osteoblasts. Glucocorticoids, we all know, are bad for bone. Radiation therapy kills off lots of things, including osteoblasts. And anti-estrogen therapy is the major one that we'll talk about. So estrogen is good for your bones, but it's bad for breast cancer. So we all know that after menopause, bone density heads south, so you rapidly lose bone. If you put people on hormone replacement therapy, you can reverse that initially and then stabilize the process. So give estrogen back, you prevent that. And how much estrogen you have as a postmenopausal woman matters. So these are all low estrogen levels from the study of osteoporotic fractures, but you can see there's a threshold. So if your circulating estradiol level, probably because you're thin and you don't have much adipose mass, is below 5 picograms per ml, your risk for fractures is substantially higher than if you have higher estrogen levels, and we'll come back to this when we talk about aromatase inhibitors. So again, WHI results, if you give people with postmenopausal women hormone replacement therapy, you can definitely reduce the incidence of hip fracture by about 50%, but you, after a specific lag time that people still argue about, you definitely increase the risk of breast cancer. So there's this inverse relationship between estrogen and osteoporosis and breast cancer risk. So why does estrogen deficiency lead to bone loss? Well, the first thing it does, and don't have time, and I wouldn't go through all this whole algorithm anyway. Lots of people have devoted their lives to studying this, but the main thing that it does is increase osteoclast formation, activity, and lifespan. So you get more bone resorption when you remove estrogen, primarily because a lot of cytokines that control this process have estrogen response elements and are suppressed by estrogen. It also has an effect on osteoblast activity. So normally if you increase osteoclast activity, the osteoblasts speed up to balance out the effect, but estrogen deficiency causes the osteoblasts to not quite keep up, so the net effect is bone loss. So, and why does this happen? Well, from our own work here, I had to throw in one slide. It's not random that estrogen and bone loss in the breasts are associated with one another, because during lactation, of course, the breast exists to make milk, right? During lactation, suckling actually induces hypogonadotrophic hypogonadism, low estrogen levels, which is important for mobilizing calcium from the bank, which is the skeleton, in order to be used for milk production. So there's this three-way conversation between the brain, the bone, and the breast that happens during lactation, and this is recapitulated both in the setting of treatment-induced osteoporosis as well as bone metastases, which we're not going to be talking about today. So let's talk about specific therapies and their risk here, and I better speed up here a little bit. So tamoxifen, just a few words about tamoxifen. So there's this kind of lore that if you're taking tamoxifen, you're all set. And that comes from the fact that tamoxifen is a mixed estrogen agonist-antagonist. If you have high estrogen levels, it acts primarily as an antagonist. If you have low estrogen levels, it acts as a mixed agonist-antagonist. So if you're a postmenopausal woman with low estrogen levels, relatively thin, then for trabecular bone, tamoxifen will act somewhat like estrogen and protect your skeleton. However, if you're obese, if you have high estrogen levels, and if you're premenopausal and you get put on tamoxifen, it will actually cause bone loss. So it's not really true, and it doesn't really have much of an effect on cortical bone, which is in the hip and the wrist. So it's not totally true that you're all fine if you're taking tamoxifen. And just to convince you of that, here's what happens in spine bone mass. So it's protected if you're on tamoxifen compared to if it goes down. But you can see that changes in the radial and the wrist bone mass, tamoxifen has no effect. If you look at fractures, so this is a case control study from the Danish Health Service, and here are the statistics here. But you can see that, again, there wasn't really a change in vertebral fractures, and that's good. Probably plays into the effect of the protective effect at the spine. But hip fractures, you weren't protected if you were on tamoxifen. So the one thing I would say about tamoxifen is, for clinicians, is don't, if someone has osteoporosis, this is not a first-line anti-osteoporosis drug, and I would not not treat someone's osteoporosis simply because they had breast cancer and on tamoxifen. So what about aromatase inhibitors? So these are very effective at reducing circulating estrogen levels. They lead to accelerated bone loss and increase the risk of fracture. So if you measure estrogen levels on people on aromatase inhibitors very early on, these third-generation aromatase inhibitors are very effective, and you reduce estradiol levels to very low levels here by at least 95%. And that's the whole point of the drug, right? This leads to accelerated bone loss. There are several trials looking at this, and we're not going to go into the details of each trial, but just to highlight the ideas here, you can see that at 24 months, here in the hip and in the spine, that if you're taking letrozole, you have more bone loss than if you're taking placebo. Okay, so postmenopausal women on you lower estrogen levels further, you speed up bone loss. So here's the ATTACK trial using an anastrozole, and this is like, so this literature is a little bit complicated, but most of these studies, that last study was versus placebo, but I think it's the only one. So all of these are combination with tamoxifen. So it's a little unfair, and I think it's led to a little bit of excess fear about aromatase inhibitors, that, oh my God, people's bones are melting away, because the comparison is people who are on tamoxifen, and especially at the spine, it looks like the effects of aromatase inhibitors are a little bit magnified. Not to say it's not a problem, and we shouldn't take it into account, but again, here at the lumbar spine, if you're on aromatase inhibitor, your bone density goes south compared to tamoxifen. Same thing at the total hip. So this causes fractures. So again, the same Danish Health Service study. If you look at now, there's no subtle point here. If you look at any fractures, hip or forearm fractures, Not sure why they didn't have vertebral fractures recorded here, but you can see that if your odds ratio of having a fracture, whether you adjust for other factors or just use the crude odds ratio, is highly elevated. So here is the, again, another trial with letrozole versus tamoxifen, looking at fractures over time, over 5 years here, and you can see that although letrozole is good for preventing disease-free survival events, it's not good for fractures. But the good thing about aromatase inhibitors is the fracture risk only exists for the time that you're taking the drug. So here's the ATTACK trial, a 10-year follow-up, and after people were taking off either tamoxifen or anastrozole, you can see that the risk, elevated risk for fractures, goes back down to baseline. So this has led to the question about, can treatment-induced bone loss be prevented in breast cancer? So again, aromatase inhibitors cause accelerated bone loss, but only during the time that you're exposed to the drug. So the idea is, well, maybe you can treat with anti-osteoporosis drugs during that treatment time, prevent bone loss, and hopefully prevent fractures, although all these trials have been underpowered and not really designed very well to look for fractures. So, but they do prevent bone loss. So here's a, from Dr. Santon's review last year, here's a table of all these, summarizing all these trials. I don't know how well you can see it here, but if you're on aromatase inhibitor versus a bisphosphonate, this is negative, this is positive, this is negative, this is positive, so on and so forth. And importantly, if you're a premenopausal woman, put on a GnRH agonist to suppress your ovarian function and put on an aromatase inhibitor, you have whopping 70% bone loss, but that's completely prevented by being treated with a bisphosphonate. So that's a critically important group to keep in mind. So here's the ZFAST trial, which was the biggest trial and got the most press and 5-year data. I'm not going to go into the trial design. It's a little bit complicated. Breast cancer people probably know about this. But if you're taking a bisphosphonate, in this case zoledronate, you do better than if you didn't. And depends on, most of these are patients who weren't treated versus patients who were treated in a delayed fashion. The other drug is denosumab, and we didn't really get to talk about rank ligand signaling, but this is a different type of anti-osteoporosis drug. Prolia is the brand name, and this is 252 postmenopausal patients. Again, I have to say Amgen has done a much better job than Novartis did in terms of studying this problem, in terms of designing appropriate trials to look at bone endpoints. And you can see that there is definitely, if you're taking denosumab, an increase in bone mass compared to a decrease at all these different sites. They actually are doing what is needed, and what's never going to be done for zoledronate is a fracture trial that's ongoing, and there already is a fracture trial in prostate cancer showing that denosumab not only affects bone density, but it also prevents fracture, which again, like I said, is who cares about your bone density number? It's whether or not you have a fracture clinically that we care about. So this has led to a proliferation of guidelines that are kind of, you're not supposed to be able to read this because they're all over the map, and a lot of anxiety in patients about this. And what we decided about a year or so ago, a little bit more, is that it would be good to with the opening of Smilow Hospital, to develop a bone health program. And the idea was not just to have a clinical service, but to actually have a program where we could start to attack some of these issues that remain. So the idea was to come up with a system by which we would standardize the evaluation, treatment, and prevention of bone complications due to cancer therapy, not just in breast cancer and prostate cancer, but all cancers. And devise and implement together with the disease-specific oncology teams, disease-specific protocols for diagnosis and treatment of osteoporosis associated with therapy. We wanted to have a physical clinic that was integrated into the supportive oncology program, and hopefully eventually staffed by endocrinology and oncology, and have fellows from both training programs rotate through. And importantly, since everything would be standardized, that we would initiate and maintain a clinical database of all patients to start supporting clinical investigation and translational investigation in this area. And I talked to several colleagues across the nation. One of the problems with doing fracture trials is you need thousands and tens of thousands of patients. So to form a consortium around this problem, and had talked to people at MD Anderson, Michigan, Indiana, Seattle, and the Brigham so far, all of whom are interested in potentially setting something up. So, and then hopefully use this to begin with, and then gradually move into expanding to the investigation and treatment of bone mets, which is still a recalcitrant problem in all cancers. So the first thing we did is sat down with the breast oncology group and come up with these institutional protocol for breast cancer patients. And so I guess I have a few minutes. We can actually go through this. So the idea is that everyone would get a standardized workup, hopefully before they came to see patients. They would have the ability to be evaluated in the bone clinic, depending on the preferences of the oncologist. And then we would use T-scores and clinical risk factors to decide who we should prophylax when they went on an aromatase inhibitor. So if you had a T-score of greater than minus 1.5, you were probably fine, and we would recommend repeat bone density in 2 years. If you have a T-score in this gray zone, if you have a T-score of less than minus 2, most of the literature and guidelines would suggest you're at increased risk for developing osteoporosis during the 5 years, or perhaps now more than 5 years, that you would be on an aromatase inhibitor, and that you should be prophylaxed to prevent further bone loss. And if you fall into this gray zone, then we would use a combination of clinical risk factors to tilt you one way or the other as to just close observation versus upfront treatment. And all patients would get these kind of, I tell my patients, clean living guidelines here: have enough calcium, vitamin D, exercise, weight training program. Hopefully we can, once this gets up and running, we can get people to partner with gyms in the area, because that's very important for osteoporosis prevention. So there are lots of clinical and research questions, and part of the reason of trying to get this set up the right way at the beginning is that some of these questions really need to be answered from practical clinical standpoint. So does this FRAX algorithm work in cancer patients? What about denosumab versus bisphosphonates? A bugaboo that I have is that for some reason or other, Novartis decided to use 4 milligrams twice a year. So that's the standard for prophylaxis for zoledronic acid. When we treat patients, we use 5 milligrams once a year, which is more than adequate. You're taking, we didn't really talk about osteonecrosis of the jaw, but you're increasing someone's exposure to the drug, I think, unnecessarily. But we could start a trial with the Brigham right away, comparing this if we wanted to get once we got this up and running. And then what about our only anabolic agent, PTH? Is that safe in the setting of cancer patients? I think there's some preclinical work as well as eventually clinical work that is interesting to do. And then there's new drugs coming down the pike, and Yale, whether you're aware or not, has an illustrious history in both bone disease as well as elucidating the mechanisms of metastatic hypercalcemia. And, darn it, we should be on the radar list when it comes to new drugs for clinical trials down the road. So anyway, that's the idea. Hopefully it'll eventually come to fruition, and I'd be happy to answer any questions.